Good evening, everybody. My name is Dr. Gigi El-Bayoumi at the Rodham Institute. I'm on faculty at the George Washington University Medical Center. Welcome to this edition of the Rodham Institute's Impact Speaker Series. I'm going to go ahead and ask for the slides to be pulled up. But while we're doing that, one of the challenges during this pandemic of COVID is that a lot of other chronic diseases have sort of taken the back seat. There is one statistic that there has been as many as a 30% reduction in the number of cancer diagnoses that have been made, which is of course particularly concerning for communities of color where delays in diagnosis are already problematic. You add that to that, and unfortunately we're going to see an increase in cancers presenting at a later date. So this series or this edition is dedicated to advances in colorectal cancer treatment, what you should know, and we'll be covering sort of the basics, including screening and prevention, but also treatment. And to help us with that discussion, we've got two wonderful speakers. We'll go back to the other slide. Dr. Lynt Johnson, who is the Executive Director of the Liver and Pancreas Institute for Quality. He is a professor of surgery at the George Washington University. And our colleague, Dr. George Kim, who's an oncologist, associate professor of medicine, also from the George Washington University. And just remember that we've got an ongoing series, and next week we'll launch our aging series. And this one will be presented by our colleagues, Dr. Tanya Shelaby, who's a geriatrician and palliative medicine assistant professor of medicine at GW, and Ms. Prasida Moore, who is the CEO of Bodies by Prasida, and the title is Healthy Brain, Live Long with Balanced Training. And as I mentioned, this is going to kick off the series on healthy aging. And we'll have changes of the aging brain, healthy eating for blood sugar control, strong women stay young, Dr. Louisa Whitesides. You can see the other people that are going to be presenting as well. Remember that the Rodham Institute is really dedicated to improving health equity in DC. And our philosophy is that health equity cannot be separated from legal justice, from economic justice, from social justice. These things feed into each other. And we are very proud, and I welcome you to visit our website to look at our resources, especially in the time of COVID. And of course, we're coming into the holiday season and food is an issue. We've just updated our food resources. Please visit us. And education is at the core of our mission. So please visit our website. Again, our three priority areas are our youth education programming and workforce, training the current and future health professionals around what applied health equity means, and community collaborations with our wonderful partners that include Temple Praise, Pennsylvania Avenue Baptist Church, UDC, Southeast Tennyson Learning Center, Israel Baptist Church, United Medical Center, just to name a few. So here are the resources that have been updated. You can see there's food, mental health, school, testing, and we have to brace for an increase in the numbers of COVID. We're seeing the numbers go up. We've been relatively lucky here in DC in that our mayor has followed science, but that I think, unfortunately, in the winter time, we may be becoming overwhelmed. And I can't reiterate the importance of making sure that you get your flu vaccine. And if you're 60 or over, I would really urge people to get the pneumonia vaccine. Talk to your clinicians about what you can do to prevent getting real sick with COVID. And that includes controlling your diabetes and high blood pressure as well. Don't forget the vitamin D, which is an emerging risk factor, low vitamin D. So again, check with your clinicians. These are our wonderful staff. Ms. Tracy Bass, who's now the director of Doctors of Tomorrow. Ms. Christina Williams, Director of Community Engagement. She's been amazing in distributing food and meals and masks, to mention just a few of the things that she's done. And doctoral student Ms. Ashanti Carter, who's the program manager, who is also involved in workforce pipeline programs, but also has been instrumental in putting these wonderful webinar series together. So thank you to the Rodham Institute staff. Here are all of our different social media handles. I'm old school, so I go to the website, but please keep in touch. And don't forget that if you want to make a contribution, we would welcome it. And you can even direct where your contributions are. We're doing a holiday drive for families, 50 families in Ward 5, which need food and books and all kinds of coats. So you can direct it to whatever you would like to see that money going towards. So again, just to reintroduce Dr. Lynt Johnson, surgeon, and Dr. George Kim, who is the oncologist. I've given their titles previously. And welcome, gentlemen. We're so glad to have you join us this evening. And so I think just to talk about just some basic statistics. So we know that colon cancer, of course, with recent passing of the Black Panther star Chadwick Boseman, as well as other celebrities who've died of colon cancer. I think I've been getting a lot of phone calls from my patients who were reluctant to get colon cancer screening, saying, oh, by the way, you mentioned colon cancer screening. Can I get that done now? So can we get an idea about the scope? How big is this problem nationally? And then if we can kind of drill down and see how big of a problem is this in our African American, our Black and Brown communities?
Well, I guess I can start. First of all, I want to thank you, Dr. Albiumi, for inviting me back again. I guess I didn't flop too bad the first time, but I'm happy to be here. You know, I think nationally, first of all, the recommendations for colon cancer screening have just been updated. And typically that has started at the age of 50, but they have now changed those recommendations to we start at the age of 45. For individuals who do not have a history that makes them at high risk, generally that means that they would need some colon cancer screening every 10 years. And the most common, form of colon cancer screening right now is colonoscopy. There's also non-invasive testing that can be done that actually has worked reasonably well with the new product Cologuard, where they analyze stool DNA for factors that predict the colon cancer. The shortfall, however, is in detecting polyps, which oftentimes are precancerous lesions, which can be seen by colonoscopy, but the detection by Cologuard is somewhat subpar. And so, although Cologuard is very good for screening for cancers, it is not as good for polyps. Overall, the incidence, I think, or the participation of adults in the U.S. in colon cancer screening is less than 50% of individuals actually go through the process. And I think that oftentimes a lot of that has to do with the idea of going through the preparation to undergo a colonoscopy and taking time off from work, which a lot of folks don't have the opportunity to do, and then the post recovery phase of that. And I think that limits participation to some degree. I think from our minority population, there are a couple of facts that should be understood. One is that the incidence of colon cancer in African American population is higher than any other ethnic group in the US. Not only the incidence, but the incidence of death or mortality from colon cancer is also highest in the African American community. I think that some of that has to do with screening, but perhaps some of that also has to do with other factors that we are not really clear about at this point in terms of why it is so aggressive in the African American community.
So thank you, Dr. Kim. In terms of colon cancer versus other cancers, where does that fall in terms of frequency? And there's one myth that I want you to please address about colon cancer occurring more often in men than women.
So when we look at cancers across the board, colon cancer's number 3. So, you have lung, then you have the breast and the prostate, and then you have colon. So roughly 150,000 new cases a year, and about a third of the patients unfortunately succumb. And as Dr. Johnson noted, I mean, we've got to do a better job of screening. The age changed to age 45 over the last several years because we're seeing not necessarily more cancers, but we're seeing more cancer deaths in that younger population. And that's important. And I think in practicing in Washington, D.C., in our urban area, I mean, we see some of these folks, and we see some of these young women who come in with advanced disease, and it's just heartbreaking because we do our best, our multi-specialty, approach to get them treated and to get them benefiting from the therapy. But sometimes they just succumb, and it's heartbreaking. It really is. It really wears on the staff. And so the point of this is that we need to do a better job of finding these patients early so our surgeons can get in there and take the darn thing out so they don't have to come and see Dr. Kim. So,
So I'm going to just sort of talk a little bit about prevention, because prevention is something that we sometimes forget about. And yet the food that we eat, our dietary habits in particular, our exercise is extremely important. And, we're coming up on Thanksgiving, and Thanksgiving is a time that I think a lot of people are going to get together virtually, but that's also an opportunity for people to find out about their family history. So I'd like to talk a little bit more about that. Let's have you talk, Dr. Johnson, about family history. What sorts of questions should we be asking our relatives, and who is considered sort of, what's the difference between a first-degree relative and more distant relatives? Why is that important?
Yeah, so there's certainly genetic factors that play into the development of colon cancer and in other cancers as well. And I would start out by, and I tell my patients this simple way to explain what cancer is, first of all, which is our cells divide billions of times in our lifetime. And that division of the cells is almost like a symphony. The tubas play when they're supposed to play, the drums play when they're supposed to play, the violins play when they're supposed to play. Unfortunately, occasionally when these cells divide, that machinery doesn't synchronize as it should, and there's a mutation that occurs. Now, our bodies are almost like computer systems in the sense that we've got antiviral software that will go in and oftentimes correct those mutations so they don't cause a problem. But if those mutations escape the correction mechanisms, then that's what forms a cancer. Those divisions never turn off. They never stop playing when they're supposed to stop playing. And that's essentially what cancer is. And so in terms of the genetic and hereditary factors, we all should have an idea, particularly of obviously of our siblings' history in regards to any history of cancers, particularly cancers that occur at a young age. And almost as important is the siblings of our parents in terms of their cancers. And it's not always just colon cancer. These genetic mutations can occur and cause different types of cancer. So if there's a history of 2 or 3 more relatives in close relatives within the family, that is certainly something that should be a part of their historical knowledge.
Mm-hmm.
And oftentimes we nowadays have the capabilities of performing genetic analysis of these individuals to see whether or not they have a higher risk for developing certain types of cancers, and we can use preventive measures in that instance. And I don't know if Dr. Kim wants to expand
Yeah.
on that a little bit, but
Yeah.
but I
Dr.
know
Kim, what is, in layperson's terms, how should the question be posed and to whom exactly?
Well, I mean, it's not a Thanksgiving dinner conversation, obviously. I mean, it's a little more subtle than that. And, but, unfortunately, I think when people do get diagnosed, then they start exploring, oh, Uncle Joe had so-and-so cancer and Aunt Betty had this cancer. But it is important, I think, to recognize that, especially as folks get older and they die and you don't have that issue anymore. But it is, in regards to colon cancer, if there is a family member, it's about a 30% increased risk that you will eventually develop colon cancer. So that's very important to know. I think just getting a good cancer history is also paramount. Now, in terms of colon cancer, there are two particular syndromes. There's the Lynt syndrome, the hereditary non-polyposis colon cancer, HNPCC. These are folks that have cancer that develops by the age of 50. They're susceptible to other cancers. They're susceptible to bladder cancers, pancreas cancer, so other malignancies. So it's important to have a recognition of this if it's in your family line. And we're going to talk a little bit about why that's important in terms of cancer treatment. The other big family syndrome is FAP, familial adenomatous polyposis. And unfortunately, these folks present very early on with a lot of polyps, in their teens, late teens, 20s. And most of the times we have to take the entire colon out. And this is associated with all, not only just colon cancer, but other types of cancer. So in terms of family history, it's important to know whether you're one of these two types. It's pretty obvious, I would think. But it's also very important to just get a good sense of who had cancer in your family.
So the reason I'm talking about Thanksgiving, it's not my original idea. Tom Joyner, one of the big African-American radio personalities for decades now, has suggested that this is a good time for people or family reunions or other things to bring up these issues when families are together. So I don't mean to bring it up at the time that you're eating necessarily, but that is a good time to gather information. So please, Dr. Kim, tell us the difference between a polyp, of different kinds of polyps and cancer, because in asking the question specifically about colon cancer, it's important, I think, to say are there polyps, and not just to ask about colon cancer, but breast cancer, prostate cancer, any kind of cancer, lung cancer, etc.
So polyps are what our colleagues in gastroenterology find during the colonoscopy, where they are actually visualizing the lining of the colon. And there are what they call kind of growing polyps, hyperplastic, tubular polyps, which they typically can take out, tubule-villous polyps. Villous is a little more concerning, and then there are serrated polyps, which are more concerning. And sometimes they really have to get into the lining of the colon to try to take these out. And if they're not able to, they will have to refer you to a surgeon who will have to take that portion of the colon out. Now, we understand from very long time now that some of these polyps, they're precancerous, and for Pete's sakes, they can develop into cancer and start evading into that wall, and then trying to go elsewhere in the body, trying to get into the plumbing of the body, the lymph nodes. And that's where you get in trouble, and that's where additional therapy is needed. So that's why it's so important to get those colonoscopies and to get these benign precancerous lesions removed and followed.
And to Dr. Johnson's point, Cologuard will not pick those up. So I always offer colonoscopies as sort of the gold standard. But if somebody says, no way, no how, I'm not going to have it done, well, Cologuard is the next best thing, but it does not allow for polyps that may be precancerous to be removed. And in terms of things like the frequency of colonoscopies, once you have polyps, especially the ones that are precancerous, the timing of colonoscopies actually changes. It's not every 10 years, depending on the type, it's 3 to 5 years. So I just wanted to make sure that that point was made. So Dr. Johnson, what are some of the foods or habits or things that we can do preventatively to reduce our risk of colon cancer?
Yeah, our typical diet is not conducive to preventive measures for cancer. But it is well known that fruits, vegetables, things that have high fiber in particular are things that can be preventive. For a good while, it is thought that a baby aspirin particularly can be helpful in regards to the development of polyps. And that thought has changed a little bit over time. And then lastly, most recently, as you had mentioned, vitamin D and calcium are thought to be two agents that may be helpful from a preventive standpoint. On the opposite side of the screen, there is a lot of literature that suggests that excessive amounts of red meat and processed meats in particular are things that may increase our risk in developing colon cancer. And certainly here in the US, we have some of the highest rates compared to other countries in the globe.
You bring that up. I remember there's a study of the peoples of the Kalahari Desert who have zero red meat intake, and their colon cancer, I believe, is the lowest on Earth, on the planet. Other things that you would add, Dr. Kim, to the diet? Any comments?
Yeah, no, I echo the meat comments, and I guess there is a move to actually outlaw certain processed meats. It's not just red meats, processed meats, and apparently sausage is in the target there, which it's going to be hard to eat at a football game. But yeah, it's out there. And then certainly vitamin D. Vitamin D is a moving target, and we actually have a trial here at George Washington looking at different levels of vitamin D supplementing the chemotherapy. Because there's good work out of Boston suggesting that affects treatment outcomes, not just the risk of colon cancer, but treatment outcomes. So yeah, you want to at least not be vitamin D deficient. And then when you talk about lifestyles, you got to talk about tobacco. And tobacco, it's not just lung and head and neck, it's all kinds of cancer. We just have to remind people of that. And my 16-year-old son, I got to remind him about this vaping business. We don't have the data yet, but we don't necessarily want the data either. So, we have to be careful there. And certainly alcohol is another risk factor. You want to keep it to 2 drinks per night. So you want to minimize that as best you can. And you want to get out and exercise. And then there's some data with aspirin, the 325 aspirin daily. We can see reductions in colon cancer over time, over decades. So those are
I'll just add that caveat about the alcohol. Remember, when it comes to women metabolize alcohol more slowly. So the recommendations for women and alcohol are different. So 1 drink per night, no more than 7 drinks in a week. After that, you see things like breast cancer and other cancers go up. And remember, when we're talking about a drink, a shot of whiskey is the equivalent to a glass of wine is equivalent to a beer. So this actually might account for some of the differences along, communities of color that we see versus European Americans, certainly among socioeconomic and class backgrounds. In my practice, I screen everybody for vitamin D. And some of the lowest numbers that I see are actually among African Americans. The normal range is between 30 and 100, and sometimes I'll see 4, 5. And it's just interesting that you mentioned the treatment, even during chemotherapy, but also now the link between COVID. And I should just reiterate that the diet that you've just mentioned, which is really whole foods, not Whole Foods, the restaurant or the chain of the grocery store, but whole vegetables and fruits that are steamed or raw, whole grains, really minimizing red meat, trying to include fatty fish, such as salmon, for example, reducing fat, having high fiber. Guess what? Those are the diet. That's the diet that's good for everything. I have an app. I think I'd shared with everybody the last time I had a recent kidney cancer diagnosis. So I only have now one kidney. So I really have to watch the protein that I'm ingesting to make sure that that kidney continues to function for many, many decades. But one of the nice things about so many of these apps, the app that I actually have that helps me monitor my calories, it helps me monitor my sugar, my fat, my fiber, and my protein. So if you're somebody that does well by monitoring what you're eating, and actually studies show that when you monitor things, you actually tend to do better. That's helpful. We know that exercise makes a difference, but we also know that things that may be disproportionately different in communities of color or poorer communities, such as environmental health, environmental pollution, water that's contaminated, as in Flint and other urban areas, the air that we're breathing, and then the stress. We in medicine for decades have kind of poo-pooed the stress that people, have. But if we look at, and I'd like you, Dr. Kim, to comment on this, the impact of stress on telomere, shortening and what that does. Not to mention, if you're working at jobs that reverse your sleep-wake cycle. We know now that sleep is such an important aspect. Sleep problems, sleep apnea, for example, can impact that. So, Dr. Kim, can you comment to those issues?
Yeah, absolutely. And this is an important area of research, a very difficult area of research. It's over decades. It's collecting blood, looking at inflammatory markers. There's some great work being done, and we really need to get more involved at GW, to be frank with you. But, in general, inflammation, stress is not good. Okay, look at all the cancer, lung cancer, inflammation created by tobacco, colon cancer, inflammation in certain populations, Crohn's disease, ulcerative colitis. And then think about the total body stress that occurs and the associated inflammation and all the cytokine release. The body is geared up all the time. Dr. Johnson talked a little bit earlier about how cancer develops. If you're constantly replicating cells and they're in a stressful environment, not at peace, you're going to develop mutations. And so, yeah, absolutely. And if I had a magic bullet or a magic treatment that could figure that out, I think we've come a long way. And that's just an area that is very challenging to research, but we have to get engaged.
Yeah, and Dr. Johnson, we had a previous series about talking about liver disease. Can you talk about the role of fat, visceral fat, and chronic diseases such as diabetes in the role of, let's say, liver disease, but cancer in general? What does visceral fat do, and what is visceral fat?
Yeah, so visceral fat is really fat that's stored in the organs and internally. In typically, there is a difference between males and females. Oftentimes, males have much more visceral fat as a part of their composure, whereas females tend to store their fat externally. But we know that fat internally, particularly in the liver, but also in other organs, can cause inflammation such that eventually can lead to cirrhosis of the liver and the development of cancers of the liver by the inflammatory changes that occur as a result of that fatty storage that occurs in the liver as well. And so we know that obesity in general plays a role. It also plays a role, I believe, in breast cancer, although I'm not a breast cancer expert. I'm not as familiar with obesity as it relates to colon cancer, but certainly as it relates to the liver, it is a definite precondition to developing some hepatocellular carcinoma.
Mm-hmm. So we talked about some prevention, some strategies to change, our habits. And one thing that I've always been amazed by is our bodies and how forgiving they are, how resilient they are. And that if we've not been following the greatest diet or, the greatest sleep habits or not really exercising, if we can make changes that are sustainable over time, we actually reap the benefits. So it's never too late to make changes. I think that's important. So let's say now that a person comes for the colonoscopy and, there are barriers. I mean, that prep that you have to drink, I know that they're always working on reducing the amount that you have to drink. People actually have the choice of following a liquid diet for 3 days prior. It's not always a prep if you can't tolerate it. People are worried about the actual colonoscopy procedure, and I'm here to reassure everybody you have no recollection of it. They give you something that makes you forget. I know that Tom Joyner and others have encouraged people to have a buddy that can take you to get the colonoscopy, and then you can pay them back, because taking time off can be an issue. But remember, places such as GW are open on Veterans Day and Indigenous Peoples Day. So there are times that people may have a holiday where we're actually open. Now let's talk about the diagnosis. So somebody has a new diagnosis of colon cancer. Who do they generally see? Do they start off with you, Dr. Kim, or do they start off with you, Dr. Johnson?
So hopefully they start off with the gastroenterologist who, as we said earlier, clips that polyp out and finds out that it's an early stage cancer, and they're going to bring them back in 6 to 12 months and keep surveillance, and hopefully they go on and don't have to deal with any additional cancer therapy. That's what we call stage 1 colon cancer. The stage 2 is when the tumor starts invading through the wall. And remember, these are all tubes, and the cancer start inside the tube and then work their way out. And so that's where a colorectal surgeon, like an OBS or umopathy, would be called, and they would come in and hopefully do it robotically here at GW, and then take it out and make decisions as to whether post-operative chemotherapy is indicated. The next stage will be stage 3. When you have the two on the outside of the two are these lymph nodes. The lymph nodes are the collection system of the body, and these little tumor cells like to get in there and try to go elsewhere. And if the patient has a lymph node positive tumor, then they're going to have to visit me, and I'm going to give them chemotherapy for 6 months or 3 months, possibly, depending on how they do and how they look. The next stage will be stage 4, and that's where Dr. Johnson is key. Some of these folks, unfortunately, have advanced cancer. It's gone to other parts of the body, to the liver, possibly to the lung. And now we got to be more sophisticated. We're going to give them everything we got. We're going to give them chemotherapy. We're going to try to take the darn thing out with a scalpel. We may have to give some radiation. But stage 4 is typically, not a good stage to be in, but we can salvage these patients, and we can really provide them long-term survival and keep them going, keep them on the road. So those are the stages, and that's how you get referred to, depending on the stage, to which specialty.
So when do you see them then, Dr. Johnson? What stage?
Yeah, so I'll speak a little bit for my colorectal surgery colleagues. Oftentimes the diagnosis is first made by colonoscopy, and then if they find a mass, they would biopsy that. And generally speaking, if it is confined to the colon, then those individuals would undergo an operation. Most often, as Dr. Kim mentioned, it is a minimally invasive operation now, with small incisions and using cameras and instruments so that they can remove a part of the colon and put it back together. Occasionally, patients will not only present with the mass in the colon, but they will also present with spread or metastases of that into the liver as the first stop. The colon is very predictable, and that is that the blood flow from the colon goes directly into the liver, which is why those cells traverse there first. And that's where I play a role. Unlike a lot of cancers that are stage 4, where the only option is chemotherapy, for colon cancer, often even in those that have stage 4 disease, it is a combination approach. We do some chemotherapy, some surgery to the colon, and then surgery to remove the tumors in the liver as well. And even in the setting of stage 4 disease, if we're successful at doing all of those 3 things, we can still provide a cure to many patients. And over the years, we've created the capabilities of extending our ability to do removal of tumors in the liver to offer that therapy to even more patients.
Mhm. So what kind of chemotherapy, Dr. Kim, and is that the chemotherapy used, is that one that makes you lose your hair, or what are some of the side effects that are associated with it?
Yeah, so we still use cytotoxic chemotherapy, intravenous chemotherapy, and it's usually a 3-drug combination. Unfortunately, it does cause some hair loss, not necessarily complete hair loss, but hair thinning. We do cause some nausea. We've got great medications for that now in 2020. We have more anti-nausea medicines that we can use. Does cause some diarrhea. We very aggressively manage that. Things like Imodium and keeping patients hydrated. And then they also can get some nerve injury, neuropathy. And that actually is one of the treatment limiting side effects that we encounter. Whoever comes up with a cure for the neuropathy associated with chemotherapy is going to get a Nobel Prize. But yeah, those chemotherapies are fairly well tolerated. The treatments are given in the clinic, and then the patients go home and sleep in their own beds at night. And we do see good responses in the 40 to 45, 50% range. We usually add a biologic or smart drug, drugs that block blood vessels that the tumors need to get their supply lines, or that block important signaling pathways. And by doing this, we shrink the tumors, and then we can hand them back off to Dr. Johnson or to our surgeons who can go in there and take out these metastases.
So what's the difference between a biologic and immunotherapy? Can you explain that to us? Because as the treatment for cancer is advancing, there are so many things that may be difficult to keep track of the different types of treatments, and certainly for an individual or for a family member that's advocating for their loved one, that it would be an important thing to know.
Yeah, so what I described a few minutes ago was cytotoxic chemotherapy. The good old-fashioned kill a cancer cell, associated side effects. Biologics in general are these monoclonal antibodies, and so they're much smarter than using chemotherapy, the cytotoxic chemotherapy. So they're monoclonal antibodies, or they're very small molecules, pills that target specific binding sites in receptors. So immunotherapy is a biologic technically. And immunotherapy, if you've been watching TV, if you watch the evening news, there are a lot of commercials about it. And it's very exciting, even in colon cancer. We're not seeing the advances that we're seeing in other cancers, but we are seeing activity specifically in what we called earlier, the Lynt syndrome patients. And so tumor cells like to manipulate the immune system. Remember, the immune system is important for knocking out rogue cells that develop. But over time, these rogue cells become cancer. They start to spread around. And we know that this is regulated by a specific pathway, the PD-1 pathway. And now there are drugs such as nivolumab, pembrolizumab, which help reactivate the immune system and to go back after the cancer and knock it out. And to get to your point, I mean, these are relatively milder in terms of side effects. You get some itis, you may get some inflammation here, you may get some inflammation there, but it's readily treated with steroids, as opposed to the neuropathy and the hair loss and the diarrhea. So most biologics are better tolerated, and they do have unique side effects. But we try to educate the patients and the families very, very clearly.
So is there a circumstance in which chemo is offered before surgery?
There is before surgery, yes, when we want to kind of shrink these tumors. And the cancer didn't just go from the colon to the liver magically. It had to transit the blood or the lymphatics. And so we worry about cells that are still in transit or somewhere hidden. Folks have to remember that we can't see individual cancer cells on our best imaging, our PET scans, our CAT scans, our MRIs, we can only see 1 million cells. So that means there's 10,000 cells floating around, 100,000 cells floating around. We want to try to annihilate them, get rid of them with the chemotherapy. So we'll do that. We'll try to clean up in between the two sites, and then we'll do the surgeries to get the big tumor cell numbers out of the patient.
Mm-hmm. One of the things that I think can be scary or worrisome to patients, Dr. Johnson, is the prospect of a colostomy. Can you talk a little bit about that? And, you know, what are some of the advances there that allow people to live normal lives with a colostomy?
Sure, sure. So, you know, the colon is separated really in the 3 parts, and it's almost like a horseshoe. The first part starts on the right side, and then you have what's called the transverse portion of the colon, and then you have the descending portion of the colon, which ends up in the rectum. The rectum and the anus has muscle fibers around the very end of the colon that helps us control when we move our bowels. The closer the tumor is to those muscles or the sphincters, the more challenging it is in order to remove it and remove all of the cancer cells and also maintain the function of those sphincters. You know, with robotic surgery, that has increased the capabilities of being able to remove tumors further down and closer to those sphincters, and allowing us to restore the continuity of the colon so people are able to go to the bathroom in the normal fashion without a colostomy. Oftentimes, because that connection can be fairly tenuous, what the surgeons will do is to do a temporary ileostomy to allow the stool to come out on a bag just temporarily while the healing occurs, and then a second operation to go back and put everything back into continuity. That's the most common way that those connections are made now, particularly for patients who have rectal cancer. For patients who have tumors further up in the colon, either in the descending, transverse, or the right colon, it's generally not an issue. You usually can take part of that colon out and put it together, and they won't end up with a colostomy. But as I said, if it gets involved in those muscles and the sphincters, then that's when typically patients have to end up with a colostomy. But I would urge anyone who has a diagnosis to get first and second opinions with colorectal surgeons. And as I mentioned, that's the big advantage of robotic surgery right now, is the capability to go deeper and closer to those muscles and being able to restore the normal function and continuity of the colon.
So we have a question from one of our audience members. She has difficulty in getting a colonoscopy because there's some scar tissue in her colon. She has 2 brothers that have colon cancer. Is there, sort of an alternative that can be safe to visualize her colon other than a colonoscopy? Or I happen to know that, for example, Dr. Borum, who's one of our gastroenterologists, in that situation may use a pediatric scope, which may be safer. Can either of you comment on that?
Sure. I think that's, the scopes come in different sizes. And so the pediatric scope is one thing that can be done. There's also a CAT scan known as a virtual colonoscopy, where they can get a relatively reasonable look at the lining of the colon that Dr. Kim had mentioned, using contrast materials. I'm very excited about the development, and it's still a few years away, of what we call liquid biopsies. And I think that within the next 5 years, they're going to be available where you can go in and get a blood test, and that blood test can detect what we call circulating cells or circulating tumor DNA, and be able to be as predictive as, at least as a Cologuard. It likely is not going to pick up the polyps just like Cologuard doesn't, but those will all be alternatives. And the most important thing is, I think it will bring more people into some sort of screening modality that will allow us to catch more tumors at an earlier stage, and therefore able to be more successful at eradicating their cancers.
Which is really the key, early diagnosis. And we mentioned some groups that are at higher risk of colon cancer, and those are people with a family history. We should also include people who have inflammatory bowel disease, such as ulcerative colitis, such as Crohn's disease. Are there other diseases, chronic diseases, that put you at higher risk besides sort of the genetic, the family history, and inflammatory bowel diseases that we should mention?
Dr. Kim, you want to take that one?
Well, I thank you for mentioning ulcerative colitis again. I think we might have skipped over that. And some folks, you have to remember that the disease can flare and then it quiets down as they get older. But these folks sometimes get lost to follow-up, and they really are at risk for cancer roughly 10 years later after the onset of their disease. So, I've seen that unfortunately in my clinic. Sometimes the patients will forget to go see the gastroenterologist, and they'll come back with advanced cancer. So it's very important. I think we've talked pretty much about the ulcerative colitis, the inflammatory bowel folks, the Crohn's folks. Those are the major ones that need to be monitored.
And so when is it, should an individual or a family member consider enrolling in a clinical trial? At what stage of the disease should people think about that? Because after all, we're in DC, the NIH and the National Cancer Institute are, not very far. We, our various academic medical centers, also are sites where there are clinical trials. There is the advantage in clinical trials that all the screening and the treatment is free. So when should somebody think about a clinical trial?
I think they should consider it at all stages. I mean, I think that if there are opportunities to participate in a chemo prevention trial, let's say you do get a colonoscopy and you have a polyp, and there's a new medication that potentially will reduce the risk of colon cancer, absolutely, you should try to participate. And I think our audience, we're trying to address certain folks that need to get more involved in research and in prevention of disease, and I think that's absolutely appropriate. For me as a medical oncologist, someone who gives chemotherapy, we're always trying to identify new treatments. So we're always adding drugs to therapies. We have some trials, as we said, the vitamin D study here. We would love for patients that are undergoing treatment to think about taking one other therapy, one other pill, and hopefully this will be the next advance. This will be the next standard. Another trial that we're doing is to look at a new drug. This drug blocks the blood vessels, but also blocks signal transduction. It's first being tested here in the US. GW was selected as one of the participating sites. So yeah, I mean, I think being part of cancer chemotherapy trials is very important. I think Dr. Johnson will also tell you there are important surgical trials, important radiation trials, important radiologic trials that are available to folks. And it's so well regulated these days. There's so much oversight. It's not these problems that occurred early on. It's really very well regulated, and pretty much we add to a standard therapy and not just give a placebo. So
yeah, I think that you're alluding, of course, to the Tuskegee Trial, which has really turned a lot of people of color, specifically African Americans, away from trials, which it's almost like sort of folks have thrown out the baby with the bathwater, because what happens is that if you're not getting information about people from Black and Brown communities, then the research is really extrapolated or derived from people who may not be sort of exactly like you. For example, I underwent genetic testing, and 84 of the genes, they were negative, but are there people that are like me? Are those genes, being tested for? I don't know. So clinical trials may have a negative sort of initial reaction. But as you said, Dr. Kim, the reality is that the oversight And, this is why it's so important to have a diverse scientific workforce. There's also community boards that sit on these trials to make sure that any kind of abuse potential, if you will, is addressed. Dr. Johnson, tell us about some of these surgical trials. How does that work?
Well, I think that oftentimes they are done in with combination therapies, where particularly we try to extend the indications for doing certain types of procedures. Historically, surgery has only been done when individuals can kind of eradicate the tumor totally. And what we're now finding is that as our colleagues in medical oncology have improved drugs and therapeutics to use, we can extend, the capabilities of doing surgery. And you mentioned earlier on the use of some of these drugs ahead of time to shrink the tumors and then go in and do surgery afterwards. That's certainly something that we would often participate in. But as it relates to metastatic disease or disease that has gone beyond the colon into the liver, there's a lot of one of the new initiatives is what's called a ALPS procedure. And it's a little bit of a complex concept, but if you will, the liver has a regenerative powers. And so that if you take out part of the liver, the other part will grow. And so patients who have tumors on both sides of the liver, where we can't take out both sides of the liver at one time, there's ways for us to take out the tumors on one side and then tie off the blood supply to the other side, make a slit in the liver between the two halves, and the body confuses itself and thinks that you've already taken that part out and the other part will start to grow. And then you go back a second time and take out the liver with the rest of the disease in. So there have been a number of advances, and all of these advances have occurred because of trials that have been taking place really globally to try to extend our capabilities of offering more eradication surgery to patients who have diffuse disease.
And I just want to come back to the fact that there are some cancers like breast cancer where colonoscopies may be done more than every 10 years, more frequently, like maybe every 5 years, depending on the age. And then finally, to think about getting genetic testing if you have had a cancer at the age of 45. When you're young, you should really consider genetic testing. Dr. Kim, you mentioned chemo prevention. I know that that's something that's available in breast cancer. Can you tell us what that is and what the prospects are in colon cancer?
Yes, we talked a little bit about this earlier about the aspirin. We know that aspirin, probably a 325 milligram every day, can reduce the risk over time. So we know that data. The other data, as we spoke about, was the vitamin D. I know we've done a lot of trials with what they call COX-2 inhibitors, which are kind of a derivative of a safer form of aspirin. We've been doing those trials for some time. So those studies are out there, whether they're primary prevention, and again, those are very hard trials to do, or secondary prevention. So for example, you had a colon cancer, you had colon surgery. Now we want to give you treatment to make sure that doesn't come back or that you don't develop a second cancer. So those trials are out there. We've used drugs like metformin, we use the statins. I'm not sure the data is strong there, but those are the sorts of studies we do as kind of chemo prevention.
Mm-hmm. And I know that we're closing in time. We've got about 7 minutes. I want to make sure that any audience members who may have questions get a chance to ask. But are there other questions that maybe we did not ask or we were not covered that either one of you would like to bring up that you think are particularly important for our audience members to know about?
Well, I guess the only thing I would say, in terms of some of the symptoms and signs of colon cancer, I think it's important for people to understand that if they see particularly blood in the stool, that's something that is not normal, and oftentimes can be a signal that there's a cancer in the colon, and also change in their stool caliber so that the size of the stools become very thin in nature. And so changes in the bowel habits that persist over a period of time is something that should definitely be checked out with your internist and or gastroenterologist, because that can be an early sign of cancer.
I often see people kind of dismissing the blood because they'll say, "Oh, well, it's from a hemorrhoid," or they'll self-diagnose. And I remember actually a physician's wife had had a colonoscopy 2 years earlier, and she came to me and she had some blood in the stool, and she says, "No, no, I think it's a hemorrhoid." I said, "You know what? Why take a chance?" And sure enough, she had a colon cancer. So I'm sure, Dr. Kim, you hear these stories all the time. Anything that you would add to that?
So it's also not just the presence of blood, that's very important, but also what the stool looks like. You know, does it look like a pencil? Does it look flat? Changes in the caliber, changes in the bowel habit. You know, are you having more diarrhea, more constipation, abdominal pain, certainly, and then changes in your appetite, your weight, your energy level. You know, are you getting more and more tired? And then also, are you getting short of breath? Those are signs of some anemia. And, you know, if you're bleeding from the gut, you develop anemia. So those are some other considerations as to when you should seek medical attention.
So let's talk about screening and treatment in the time of COVID, because people are so worried about that, about contracting COVID. Can Dr. Kim, can you speak? I'd like to know, you know, in the clinic, I know that we've been keeping statistics about how many patients have gotten sick just by coming to see us in the clinic. What do those numbers look like at our outpatient clinics at GW?
Yeah, we're actually looking at this closely, and I think it's pretty good that we haven't seen a lot. Remember, we're around immunosuppressed chemotherapy patients, and you know we really have not seen COVID being transmitted in the infusion center. We've done the precautions, thank goodness, and we've done pretty well. I know that for folks going for colonoscopies and procedures, they're required to undergo a COVID test 2 to 3 days before the study. So, you know, I think we've done a fair job. Certainly not rampantly running through the hospital or the clinic when these procedures or treatments are being given. So that's good news, I think.
Yeah, no, as far as I know, as up to maybe a few weeks, this may be old information, there were actually no patients that had contracted COVID from coming to see us. Dr. Johnson, I know that a lot has changed in terms of, especially when people are going on a respirator to be put under anesthesia to prevent COVID. What has the surgical sort of protocol, how has that changed in the era of COVID?
Yeah, so as Dr. Kim had mentioned, all of our patients for elective surgery will get tested within a 5-day period of their surgery for COVID before coming in. Patients who are positive are typically postponed for a couple of weeks and then retested to make sure that they're negative before their elective procedure. For patients who need emergency surgery, we have a specialized room and PPE in the operating room for patients. As you know, the rapid testing can be done. So even in an emergency situation, oftentimes we will know that patient's status before the actual surgery will take place, and sometimes during. And so we do have those precautions. Patients also who are in the hospital will get tested every 5 days after surgery in order to maintain and know that they continue to be positive. So I agree with you. We haven't really seen any cases within the surgical department of patients contracting COVID while they were in the hospital. And so it's been very safe from my viewpoint.
Mhm. And so really the message of this entire sort of webinar has been, please don't stop the screening,
Right.
because although certainly COVID is deadly, there are other diseases that don't stop, whether it's chronic diseases such as high blood pressure, diabetes, or heart disease, but certainly cancer, where we know that early diagnosis it means a longer life expectancy and cure. Don't forget about colonoscopy. If that's not something that you, for whatever reason, want to do, talk with your doctor about virtual colonoscopy and Cologuard. Talk to your family members about what their family history is for all cancers. In colon cancer, also ask about polyps. And remember that the new guidelines are you begin screening at age 45. That is new, and that's for men and women. Look at ways to prevent any kind of cancer and stay healthy by following a diet that is rich with fruits and vegetables, that minimizes red meat, that eliminates tobacco, and also you're monitoring your alcohol intake, increase your fiber intake, especially for colon cancer, and keep your fat intake down. Again, you can follow apps. Exercise makes a difference. I think, though, that the key in all this is to be educated and to stay informed. And you know, there are so many websites now that you can get information. Our partner, blackdoctor.org, has a whole host of wonderful information. The Mayo Clinic, I think, also has great information. The government, the NIH, the National Cancer Institute, great information, whatever works. But you have to have, I think, a good relationship with your clinician so that you can ask questions, so that you don't feel rushed, where you feel like you're being heard, where the doctor or the clinician, nurse practitioner or PA is asking you those questions and saying, hey, you know, I noticed that you have had Crohn's. When was the last time that you had a colonoscopy? That's what a good internist, what a good doctor, a good clinician will do. I see we're out of time, but I just want to thank both of our panelists, Dr. Lynt Johnson and Dr. George Kim, for just a robust discussion that I think covered just about everything I can think of relating to colon cancer. Thank you so much to the both of you.
Thank you.
Thank you very much for having us.
Yes, and for anybody that's interested, this talk is going to be uploaded on our website at our speaker series, and I hope that you can join us for next week's talk. Thank you very much, everybody, and have a nice evening. Good night. Bye-bye.